memory on the treatment paradigm, which we haven't specifically talked about. We don't do radiosurgery every day here because we have other things to do, like surgery. What we do is we have a radiosurgery clinic on Monday afternoon that we run jointly with radiation oncology. We see anywhere from 4 to 12 new patients. We review their history, physical, and imaging data, and decide with them whether radiosurgery is the best treatment option. If it is, they stay in the hotel on Monday night, and so that usually they're from quite a ways off. They don't have to make another trip. We've already got them scheduled for treatment the next morning. They come in at 6:30, they get Valium. At 7 o'clock, we start the head ring applications. Some of you have been there. That takes about 4 or 5 minutes per patient, and this is the head ring going on under local anesthesia. This, back in the old days, and rarely today, we would do angiographic, stereotactic angiographic localization, and this is an angiographic localizer. But we don't do much angiography for radiation anymore. This is what the digitized angiogram looks like on a digitizer screen. And we're not going to go into a lot of detail about the problems with stereotactic angiography, but I would just point out these 3 papers. I think we were the first group to realize that there were a lot of inaccuracies with angiography, and the bottom line problem with angiography is that although it is a wonderful diagnostic imaging database, and it's a good platform for endovascular therapy, it's 2-dimensional, it's not 3-dimensional. And the targets that we're treating are 3-dimensional. So you can, depending on the axis of orientation of the target to the 2 planes of the angiogram, you can under or overestimate the diameter of the lesion by basically the hypotenuse of a isosceles triangle, which is the square root of 2, 1.4. It's a pretty sizable error, and also any excrescences, any departures from circular, spherical anatomy are very difficult to determine on an angiogram. So for that reason, rely on CT angiography. As we didn't get around to showing you that yesterday in the dose planning, but we basically do a large volume injection of IV dye immediately before the CT is performed. This is in the old days when I had no gray hair, and the CT scanners were really slow compared to today. We would actually have to scan half the head and then stop to let the tube cool down, and then scan. Some of you may remember those days. Now it's just a few seconds to scan the whole head, but it was quite a project. It's very easy now. We have a well worked out protocol. The CT techs know how much dye to inject, when to inject it, when to start the scan, and we get some beautiful images which can then be reconstructed in any plane, and you have a true 3D. Other institutions use MR angiography or MRI. The point is, and many of them still use angiography, but I don't know why. But the point is that you have to incorporate a 3D imaging modality for 3-dimensional dose planning. So the dose planning process, which we reviewed yesterday, it takes some time to learn how to do dose planning. There are many different approaches to it, but the goal is easy to understand, right? The goal is conformality. If we don't include the entire target, we're going to reduce our cure rate. If we include normal brain, we're going to increase the complication rate. And so we use sphere packing here, and Here's an example of an AVM involving the corpus callosum. The red line is the treatment line, the green line is half the treatment dose. It took multiple isocenters to contour this non-spherical lesion. Here's a choroidal AVM. Same thing, you can't plop a circular collimator on there. You have to work at this, you have to get a conformal plan. And so while we have the patients, we do put the rings on, we get the CAT scans, they wait and have breakfast with their families while we are doing the computer dose planning, which doesn't take very long. And they're connected to the machine one at a time, and the isocenters of radiation are delivered, and the treatment time actually in the machine is directly proportional to the number of isocenters that are needed to generate the conformal plan. So it takes about 10 minutes per isocenter. Most of the plans are 2, 3, 4 isocenters, so it's under an hour on the table. Occasionally we'll have a 15 or 20 isocenter plan, and that means that Frank Bove is going to be here for a long time getting the treatment done. This is the Trilogy Varian machine that we currently use for radiosurgery. It incorporates all of the hardware and software developed and patented here at the University of Florida for radiosurgery. And really, the new feature is this part, which is a cone beam CT imaging system, so that you can image and treat on the same table, and that enables us to take radiosurgery out of the head and apply it to tumors elsewhere in the body. And for neurosurgery, that's usually going to be a spine tumor. For other specialties, it could be lung, pancreas, liver, prostate. All right, so as of, I think this is maybe 6 months ago, I compiled this data. As of that time, we had treated 654 patients with arteriovenous malformations. And the median age is typical for AVMs, 30s, 40s. The treatment volume is 7 cc's. Now, when you get into the radiosurgery world, you start thinking about volumes. We don't, a lot of the time we think about diameters in neurosurgery, right? That's how we measure things. But again, we're dealing in 3 dimensions. So a 10 cc volume is equivalent to a 28 millimeter sphere, and that's getting up towards the high, medium, large range for radiosurgery. Number of isocenters, as you can see, most of these are sort of spherical or elliptical, so we were able to treat them with 1 isocenters, but there have been a considerable number that needed greater than 9 isocenters to generate a satisfactory plan. And the magic dose for arteriovenous malformations is 2,000 centigrade. Remember, the magic dose for vestibular schwannomas is 1250. Well, the dose that we want to give to produce a high chance of a cure to the periphery of an AVM nidus is 2,000. Sometimes we have to drop that dose a little bit because we're treating really big AVMs. And the reason we have to drop the dose is that the risk of a complication is proportional to the volume of the shell of normal brain that is getting a dose between the treatment dose and half the treatment dose. Okay? So that shell, remember, the dose gradient optimally is 3 to 4 millimeters from dose to half dose. Okay? So as the diameter of the lesion enlarges, or as the radius enlarges, that shell volume goes up r to the third, okay, because it's a volume. So it very rapidly and dramatically increases to the point where some lesions are simply too big to be safely treated with radiosurgery. And how big that is a moving target. But just to put it into neurosurgical terms, probably 4 centimeter. Above that, we're not going to treat, not even think about treating with radiosurgery. So most of the patients were seizure presentations. A number presented incidentally or with headache. A lot had hemorrhages. Small percentage had progressive neurologic deficit, presumably from steel. A number of them had been operated and still had AVM. That's not a good situation. And 55, at least 55, had undergone embolization before surgery. And these are the locations of the AVMs. These are the Spetzler-Martin grades of the AVMs that we've treated. We very rarely would treat a grade 1 because they're almost always going to be low risk for surgery. There are actually a lot of grade 2s that I think most of my colleagues consider to be risky, primarily because of their location. They're small, and they may have superficial venous drainage, but they're right in the motor strip, or they're right in language area, or they're in some deeper location without deep venous drainage. So they get a score of 2, but they're high risk 2s. 3s are frequently risky, and 4s are, we know the risk of surgery for 4s is very high. It's important to realize the Spetzler-Martin grading scheme is a very useful, it's been actually revised recently by Spetzler to a 3, I think it's a 3 category system. It's very useful for judging the risk of surgery and talking to patients about it, but remember that Bob Spetzler doesn't operate on every grade 2 or grade 3. Okay, he chooses the ones that he knows he can operate on safely, and those are the patients that made up the group that the rating scale comes from. So it's a selected group of patients, and that selection bias sort of disguises some of the true risk of some of these AVMs when you look at them individually. So here's an AVM. These are just some before and after shots. Just one angiographic shot, and here is the same patient a year later. No AVM, normal angiogram, outpatient procedure. Here it's back in the days of stereotactic angiography. You can see the fiducial markers from the angiographic localizer, and I drew this outline because I was tracing the nidus outline on the computer screen. But again, 1 to 2 years later, the AVM is gone. So let's look at the results for the whole group. And we're going to divide the AVMs into different size categories. We have very few A's, but they would be very small AVMs. B is 1 to 4 cc's, C is 4 to 10, and D is greater than 10. And again, greater than 10 is getting to be in the group where we know our success rate is going to drop off. So if we look at the angiographic cure rate for the entire series, you can see that the cure rate is very high. It's above 80%, one treatment for the A, B, and C, but it drops off to about 50% for the D group. So the overall cure rate for one treatment measured by angiography is 77%. If you look at angio-MR cure rates, the results are a little different, and this is important. The English language is quite complex, and if you use it skillfully, you can make your results look better or worse, than they really are. The way that a radiosurgeon might do this is by failing to inform you that the practice pattern is that we do the treatment, we get an MR scan every year after treatment, and when the MR shows that the AVM is gone, we get an angiogram to make sure it's gone. So a lot of the angiographic cure rate is probably artificially elevated because of that. Okay, MR is pretty darn accurate. Okay, so if we use angio and MRI to judge whether the AVM is cured, you can see the number goes up, okay, in the denominator, and A is still quite high, B is pretty high, but C now is dropping off and D is down to a third. All right? So what do you do with the ones that aren't cured with the first treatment? Well, you retreat them. You treat them a second time. And so this is a paper that Kelly Foote and I and Frank put together back when Kelly was doing his research here with me, 2001, I think. And this is 52 patients who underwent retreatment. And there are a couple of important messages here. Almost all of the patients at the time of retreatment had an AVM nidus that was much smaller than it was at the time of the first treatment. So that there was a treatment response. It just wasn't a complete response. And if we retreated them, 60% of them were salvaged and cured. So retreatment was effective and retreatment was safe. So now we actually have retreated 77 patients, and 70%, our current salvage rate is 70%. So the final way that I would suggest that you look at the results of radiosurgery is to forget about the number of treatments, the treatment cure rate, and think about the patient cure rate, including the patients who have been treated more than once. And if you do that, you can see that we get a uniformly high cure rate, even in this larger than 10 cc group, an overall cure rate of 87%. Okay? So these are just, we've been in this business for a long time, so here's a paper that David Blatt wrote. Some of you may have met him in Denver. He's one of our ex-residents. And Frank and I, back in '92, here's a paper. This is the first publication on a dural AVF that was cured with radiosurgery. That's Nick Chandler, one of our residents who's in practice in Jacksonville. Tom Ellis, I think most of you know him. And we'll talk a little bit more about his work. Here is one of our medical students from a few years ago, Surisha Balampali. There he is, Kelly Foote. Here's the risk of hemorrhage after radiosurgery, David Blatt. Scott Raffa, and we're going to talk about his paper. He's a USF medical student. Does anybody know where he matched? USF. Okay, all right. He did a summer project here, and then Greg Zipfel did this paper. David Blatt again. Yeah. So let's just talk a little bit about some of the important points from these papers that have been published over the past 20 years. Here's a paper from 1998. Tom Ellis was the first author, and we looked at just two cohorts of patients that were concurrently treated, 72 of which were cured and 36% weren't cured. And what we did is we went back and we looked at the retreatment scan, and we used image fusion to superimpose the nidus at the time of retreatment onto the treatment plan from the first treatment, okay? And when we did that, we found out that the residual nidus was outside the original treatment plan in 26%, so it was an out-of-field failure. And that just means that although in my heart of hearts I feel like I'm right about where the AVM is 100% of time, I'm not. I was getting it right about 75% of the time. The answer to this is to get better and better imaging and more experience. And I think with that, probably also with increased doses that we're using these days, the cure rate can be pushed up. And the statistical predictors of failure were increasing AVM size. Of course, as the AVM goes up, I've already told you we decrease the dose, so they're not independent factors. And of course, the Spetzler-Martin score goes up as the AVM size goes up as well. So these are all interrelated factors. If we look at the paper, you can see that, below 1500 centigrade, we had no, basically the cure rate is pitiful. Okay, so we almost never go below 1750 these days. We and everybody else didn't know this back in 1998. Actually, the experience here was interesting. The first patient we treated with 1000 centigrade was cured So we treated a bunch more until we figured out that that was just like lucky, and it wasn't going to be reduplicated. And so, again, the magic dose is 2,000. We rarely go above 2,000. We rarely go below 1,750. We looked at, in another study, at a very detailed study looking at dosimetric factors. And I'll explain what I mean by that. This was the Ballin poly. And so what we did, here's an AVM nidus, okay? Now when we're looking at an AVM nidus, this is not part of the nidus. This is a big vein right here, okay? This is a big vein, okay? This is a vein over here. This is clearly a feeding artery coming in right here. I'm not sure if this is a vein or an artery, probably a vein. Here's a vein, okay? What we treat is this fluffy, amorphous stuff here. That's what the nidus looks like on a CT scan. That's all we need to treat. So a lot of times when you get a radiology report back, they'll tell you that, you know, the AVM is this big, okay? But really, if you subtract the veins and the arteries, it's this big, and it is treatable with radiosurgery or surgery, because with both, we're not trying to eliminate the arteries and veins. We're trying to get rid of this abnormal communication between the arteries and veins. So here is the outline of the nidus. Now, it's okay if you include a little bit of the vein to make the geometry simpler. But what we really need to include is all this fluffy stuff. And then we superimpose the treatment plan on that at that level and half the treatment dose. And what we wind up with is the treatment isodose volume, the AVM volume that's missed, the AVM volume that's treated, normal tissue that's treated, and we can analyze mathematically the quality of that treatment using a mathematical measure of conformality and a mathematical measure of dose gradient to come up with a score that we call the UF index. Modestly, we call it the UF index. And when we reviewed the 269 patients, in that group, there were no factors that were predictive of permanent radiation-induced complications. Now, the reason for that is that we don't have enough cases of, the complication rate is very low. So we'd have to treat a lot of patients to come up with some statistical factors. But eloquent AVM location and the volume of normal brain that received 12 gray or more, remember that shell of normal brain, basically, the volume that's receiving 12 was predictive of transient complications. And again, as in the Ellis paper, lower Spetzler-Martin scores, higher doses, and steeper dose gradients correlated with success. I don't know why steeper dose gradient correlated with success, but it did. All right, then Zipfel and I looked at AVM morphology. So if you take care of AVMs, you will recognize by looking at the angiogram or the CAT scan that some of them have what we call a diffuse morphology. They're really tough to define, and they have a lot of surrounding neovascularity that's probably not AVM, but it's tough to know where the border is between AVM and just hypervascularity of the surrounding brain. And then we have a lot of AVMs that are clearly very compact and clearly delineated, almost like a tumor. So we went through and categorized them as diffuse or compact, and the diffuse morphology, as you would suspect, was associated with significantly poorer outcomes, and that again relates to targeting. The harder it is going to be to define the target, the harder it will, the lower the success. Now, what about complications? So here's we're not able to follow all of these patients because most of them are from greater than 100 miles away. For a variety of reasons, they may or may not choose to come back or to send us their follow-up imaging. Most of them do. But of the patients that we have information on, 11 have had a permanent neurologic deficit. All were minor. and 16 had a transient deficit. This is the important point on this slide. 45 patients had a hemorrhage after radiosurgery, and 8 of them died, and a number of the ones that lived had a major deficit. So the big drawback of radiosurgery compared to embolization and surgery is that the patients remain at risk for a hemorrhage until the AVM is completely gone, and that typically takes 18 to 24 months, sometimes 3 years. So during that period, the patients continue to experience roughly the natural history risk of hemorrhage, which is 3 to 4% a year, and some of them will have severe problems from that. There's nothing we can currently do about that except take the patients who are safe for surgery and treat them surgically, because that will immediately eliminate the risk of hemorrhage. All right, so here is a small AVM in the area of motor strip. This is, again, back in the days of stereotactic angiography. You can see the little fiducials with the alphabetic labeling. And 9 months after treatment, she came back, said she had a headache. She didn't have a neurodeficit. She had a lot of edema. Of course, the AVM is just a little tiny thing, but there's a lot of edema in the surrounding brain. We treated her with steroids for 2 to 3 months, and the edema completely resolved, and her follow-up angiogram showed no AVM. So probably if you develop a transient complication, your chance of getting a cure is actually higher. And we don't know why this swelling develops. It's clearly not radiation necrosis because there's no dead brain left. It's a transient process, as in this case, but it could either be temporary damage to the surrounding brain, or perhaps more likely it's due to partial thrombosis of the AVM, especially the venous compartment. If a venous outflow compartment of the AVM thromboses and you still have arterial blood flow coming in, then you can induce either a hemorrhage or edema. And the same thing happens with embolization or surgery. If the treatment is partial, you probably increase the risk of a complication. So here's a frontal AVM. I think this AVM would be treated surgically here today. It's pretty far frontal, and it would have been embolized and removed with surgery. But for some reason, we did radiosurgery. And I saw the patient in clinic. I think this was about 15 months after treatment, and the next day he had a hemorrhage. And he came back with this scan. Fortunately, this hemorrhage caused headache and nothing else. We did not have to treat it surgically. It resolved spontaneously, and subsequently had an angiogram that showed a cure. So just because they have a hemorrhage or a radiation-induced complication doesn't mean that the radiation process, the biological process, isn't still continuing. And if you can wait it out, most of those patients will still progress to a cure. All right, just one other paper that I want to discuss, and that is a paper that I did with Scott Raffa a couple of years ago, and basically we took this AVM rating system that was developed at the University of Pittsburgh by Bruce Pollock, who's currently at the Mayo Clinic. And basically the way this works is that the AVM score equals 0.1 times the volume in centimeters, 0.02 times age in years, and 0.3 times the location, okay? And the location values are 0 for frontal temporal locations, which are generally going to be safe, 1 for parietal occipital corpus callosum and cerebellar, and 2 for basal ganglia, thalamus, and brainstem. So the higher the score, the lower the chance of an excellent outcome, okay? And this location bit is because if you have a radiation-induced complication or a hemorrhage, and it's in the brainstem or the basal ganglia or thalamus, it's very likely to be symptomatic, right? But if it's in the frontal or temporal lobe, like the case I just showed you, it might be asymptomatic, and so the patient would still be rated as having a good outcome. Why age is a factor, nobody is quite sure, but it is. Statistically, the older patients do not do as well with radiosurgical treatment. They don't do as well with surgical treatment either. So it probably has something to do with the tolerance of their brain to any kind of an insult, whether it be radiation or surgical. We also compared them to all the other publications that had used this scoring system. So there are 2 Pollock papers. There was a paper from Spain, and there are several other papers here. Okay, and we analyzed our results by single treatment, repeat treatment, and overall treatment, the way I showed you in my analysis. And so if you look down this strip, here are the scores: less than 1, 1 to 1.8, 1.8 to 2.5, greater than 2.5, and the percent of patients who fell into those categories. Here's the percent that developed a radiation-induced deficit, either transient or permanent. Here's the percent that had a hemorrhage. And then if we look at the outcomes according to the definitions I just gave you, if we look at the overall series, 62% had an excellent outcome, 5% had a good outcome, 2% had a fair outcome, 22% were unchanged, 7% had a poor outcome, and 2% died. And then if you go this way, you'll see that those numbers compare well with most of the other published series. So it's one way, if you want to, that you can mathematically analyze the chances of radiosurgical success. Now, this scoring system has been validated independently with multiple different experiences, and in clinic, you can explain to the patient, what their chances are with radiosurgical treatment. This is there are hundreds of radiosurgical publications out there, and I can send, if you go to the website, there's a chapter that I've written from Mayberg's textbook on cerebrovascular disease that has all of those papers in the bibliography if you want more details. These are just a few of the bigger published series in the literature, both gamma knife, proton beam, and linear accelerator, that show the angiographic cure rates, the complication rates, and the hemorrhage rates. And they're like anything in medicine, the centers that do large volumes of patients, regardless of the machine they're using, report the same results. All right, now we don't treat every AVM patient with radiosurgery or surgery. We have a conservative option that we can use. And what about the conservative option? How risky is that? When some of us talk about surgical decision making, it comes down to evaluating the risk of surgery versus the natural history risk. You've heard our morning conference discussions, like on grade 0 aneurysms, perhaps, okay? And the same thing applies to radiosurgery and to surgery for AVMs. You have to know what your cure rate is and what your complication rate is. Your cure rate, not mine, okay? Because I've got a lot more experience than you do, so mine's likely to be better than yours, okay? And you have to know what the natural history risk is. And then you sit down with the patient and you tell them, you're safe for having nothing. Yes, I can do it safely, or I should probably send you to a center where they do more of this. So what is the natural history risk? Well, there's a lot of literature on this. I think most of the good papers settle in on a natural history risk of 3 to 4% per year. And so that means the risk of hemorrhage is 1 minus the risk of no hemorrhage, which for this purpose we'll say is 97% in 1 year, to the n power, where n equals the expected years of remaining life. Frank, the mathematics aren't getting too complicated for you here, are they?
I made a note.
Okay. All right, so 1 year, it's 1 minus 0.97, which is 3%. 2 years, 1 minus 0.97 times 0.97, which is 6%. And 3 years, this is looking simple. You just take 3% times the number of years. No, that's not the way it works, okay, because We take that data and then we look at the actuarial life insurance tables, and that's going to tell you the likelihood that a patient at 15, how long are they likely to live? What's their actual life expectancy? Well, at 15, it's 62 more years. At 45, it's 34. At 65, it's actually 18 more years. The total number of years goes up because if you make it to 65, you're likely to be in the older end of the age spectrum. So if you take the life insurance actuarial survival tables and that formula for risk of hemorrhage, this is the cumulative lifetime risk of hemorrhage, assuming that the simple model of 3% per year for your whole life is correct, okay? And you can see even at 65, the risk of a hemorrhage, the natural history risk is quite high. Even at 70, I didn't take it up to 70. This is from a Konziolka paper. It's quite high. Probably above 70, the curves start to cross, where you want to think long and hard about just conservative treatment. Right, so the big debate, is, it's not much of a debate here, but the debate still at neurosurgical meetings. Remember that quote from Lexell about his trip to a vascular surgery meeting, and is whether you should do surgery or radiosurgery. And so I'm going to just walk you through my thinking on this, and then I'm going to do something a little simpler, but each of these statements that I'm going to make, you can argue about, but they're pretty on target. So based on what we know today, only surgery can immediately eliminate the risk of hemorrhage from AVMs, okay? I think the only addition to that statement would be if you can identify a flow-related aneurysm or an intranidal aneurysm and your endovascular colleague can get rid of that for you, then maybe you have succeeded in eliminating the high risk part of that AVM and you can go ahead with radiosurgery, but that's unproven. Statement 2, the risk of hemorrhage until complete thrombosis occurs is approximately 4% per year. Radiosurgery for AVMs less than 10 cc's has a greater than 80% cure rate. It takes approximately 2 years for radiosurgery to produce thrombosis and eliminate the risk of hemorrhage. And the risk of permanent radiation-induced complications is around 2%. So, if surgery can be done with a risk that is less than the risk of radiosurgery, so the risk of radiosurgery is the 2% risk of radiation damage, the 4% per year risk of bleeding for the 2 years it takes to produce thrombosis, that's 10%, okay? And if surgery can be done with an efficacy greater than 80%, which it almost always can, then the radiosurgeon should refer the patient for microsurgery. And a way of looking at it is that if surgery can be done safely, it should always be the first choice. And that's the discussion that I have with Brian and Steve on a frequent basis. Of course, defining safely is the tricky part here, right? And again, that is going to depend on a very scrupulous analysis of your own results, a very honest analysis. It's not easy to keep track of all your patients in a database and what their results were, like we've done in the radiosurgery database, but that's what you need to do. You can't do it for every patient you take care of, but you can certainly do it for the major patient groups in your subspecialty area. It's important whether you're in private practice or in academics. So since the risk of radiosurgery is 10% and conservative follow-up has a much higher risk, even in 65 and 70-year-olds, we don't use a lot of conservative follow-up therapy. A lot of the patients who in previous days would be followed conservatively are now treated with radiosurgery. So there are still a lot of issues that need to be worked out, a lot of moving targets in the radiosurgical world. We certainly have become more comfortable over the years treating bigger and bigger AVMs, especially if they have compact morphology. Some AVMs we know we have a low chance of curing with one treatment, but we're confident even if they're big, we can cure them with 2 treatments. The dose we pushed up higher and higher over the years as our treatment planning has become better. We've become more conformal, and as we've accumulated enough data to be confident that we rarely produce radiation-induced complication, at least permanent complications. Embolization. Embolization is a great pre-op adjunctive therapy. I think a number of papers have shown that blood loss is reduced with embolization, and I think most cerebrovascular surgeons feel that it makes AVM surgery a lot less frightening and sometimes even easy. It has the reverse effect in radiosurgery. So remember, most of these nidi are compact. They're easily visualized with our imaging modalities, and they're spherical or ellipsoidal in shape. And if you embolize them, you break them up into a bunch of poorly defined residual, multiple compartment targets that are difficult to visualize because most of the embolic material also produces artifact on both CT and MR scans. The other thing is the embolic material probably does absorb some of the radiation dose, so it complicates the dosimetry. So I believe that in most cases embolization should not be used before radiosurgery. There have been multiple publications showing that the outcomes are worse with pre-radiosurgery embolization, and you do wind up adding the risk of embolization, which is not 0, to the risk of radiosurgery, which is not 0. So you get additive risk and you get poorer outcomes. Not a good idea. Treatment of associated aneurysms, I think most cerebrovascular surgeons and radiosurgeons are, in the old days, occasionally we would treat the AVM, and sometimes the flow-related aneurysm would go away, and we'd say, aha, wasn't that brilliant? But more often than not, the patient will have a hemorrhage from the flow-related aneurysm, and we need to be aggressive about either surgically or these days endovascularly eliminating the flow-related aneurysm. Usually we do that before the AVM nidus is treated. Fractionation. There are some groups out there that do volume fractionation of AVMs, the Pittsburgh group being the best known. The results are horrible. Okay, and Doug Konziolka presented these results at the AANS meeting during our radiosurgery course, and he's very disappointed. And the idea was you treat half, you come back 6 months later and treat the other half. Well, I think maybe 20% of them wound up with a cure, and that's just not worth doing. What we do is we fractionate in time. So we give the highest dose that we think we can safely deliver to the entire AVM nidus, and then we come back 2 to 3 years later, and if there's any left, we treat again. So that's fractionation, 2 fractions. But it's to the whole volume, and I've already showed you that produces a high cure rate. Now you increase the risk of hemorrhage because you're adding on more years of latency, but you still are producing a high cure rate, and that's our choice. And the selection of AVMs which are high risk for bleeding, I don't think we're very good at that. We know that if there's a venous outflow phenomenon, they might be at higher risk for bleeding. If there's an aneurysm, they're at higher risk for bleeding. Maybe if they're periventricular, there's a higher risk. At least the bleed is likely to be more severe. There's argument in the literature still about whether small or big AVMs are higher risk for bleeding. And there are papers on both sides of the issue. If we could do a better job of identifying the AVMs which were high risk, we might be able to be a little bit more logical about which AVMs would get surgery and which AVMs would get radiosurgery. Well, this concludes our, again, this is May 18th, 1988 in this picture, so we're looking at 23 years of accumulated knowledge. Hopefully there's a little bit of wisdom in there from the knowledge as well, and hopefully I've been able to transmit some of that to you. Thank you.